Welcome to this quick summary of the DSM-5 substance-related and addictive disorders criteria, originally developed by Michael Ryan. It's important as we get started to make a couple of quick observations, one being that recognize that the primary purpose of the DSM-5 manual was to help trained clinicians identify and diagnose the conditions, the mental disorders that their clients or patients are bringing to them in such a way that we could both what's called successfully formulate their case formulation, identify who they are, understand who they are, in order that we can effectively develop an individualized treatment plan for them. The primary purpose is to help understand our clients in such a way that we can do a better job at helping them get better. We know what it is that they're experiencing. We know therefore how to best treat it. Recognize also that the criteria sets themselves are there to help the clinician identify and summarize the predominant signs and symptoms that the client is experiencing in such a way that they point us in the right direction to understand what it is that they're experiencing, i.e. the underlying disorder that they're bringing with them to the treatment setting. Also recognize that if you were familiar with the DSM-4 criteria, there have been significant and substantive changes in DSM-5 in contrast with the criteria for substance abuse and substance dependence that people who understand DSM-4 were familiar with. And in particular, we no longer have separate criteria that would identify a substance abuse and a separate substance dependence. We now have combined the substance abuse and substance dependence categories into one broader category called substance use disorders. We also then use specifiers to identify whether or not it's mild, moderate, or severe substance use disorder. Also recognize that diagnosing is done based upon the substance or substances that are being used. If a person is using two substances, i.e. alcohol and cocaine, then we would look to identify whether or not they meet the criteria for an alcohol use disorder, and then also gather and identify whether or not they meet the criteria for a separate cocaine use disorder. We don't lump everything together into one broad category, but rather make distinctions based upon the separate drug or drugs that they're using. The threshold for identifying an individual as having a substance use disorder has been raised from the previous DSM-4 criteria and now requires at least 2 symptoms from a list of 11 in order to say a person has a substance use disorder. Previously, you could be diagnosed with a substance abuse disorder if you met only one of the symptoms. In our earlier understanding or conceptualization of substance use disorders, the distinction between abuse and dependence was based upon the idea that abuse was a less problematic state in the progression of the illness, considered to be milder or early phase, and dependence was what would emerge if the person were to continue to use. It was considered a more advanced and progressed stage. The reality is that people who were diagnosed with substance abuse had some very significant and oftentimes severe problems. At this point now, by combining the substance use disorder criteria into one set of 11 criteria, we now have the ability to use a single diagnosis that will help us better define and describe where the person falls on the spectrum. It also eliminates some of the confusion that emerged with the interaction between the word dependence and addiction. Dependence is in fact a biological or a physiologic process that emerges as a result of exposure or use of a substance. Addiction oftentimes implied the relationship to the substance and the lifestyle that develop, and so we're trying to get away from the confusion of the distinctions between both addiction and dependence. It's also important to recognize that when the DSM-5 was published, there were criteria included that allowed for the identification and diagnosis of a gambling disorder. It's included in the DSM-4 with the chapter on substance use disorders because there's recognition that the characteristics of gambling disorder, i.e. how it occurs, how it expresses itself, how it activates pleasure centers of the brain, etc., are very, very similar to what happens when a person develops a substance use disorder. So as noted earlier, we no longer have separate dependence and abuse criteria. We now have one broad category called substance use disorders. There's also a separate category called substance-related disorders, which we will talk about briefly. If you've taken psychopharmacology or introduction to substance abuse, then you're going to recognize, in general, the classes that are noted here. Substance-related disorders encompass 10 separate classes of drugs: alcohol, caffeine, cannabis, hallucinogens, with some exceptions as noted here, inhalants, opioids or painkillers, sedatives, hypnotics, anxiolytics or anxiety-reducing substances, stimulants, tobacco, and other or unknown substances. What is important, again, if you've taken psychopharmacology or introduction to substance abuse, is recognition that the classes themselves are not necessarily distinct from each other. All substances that create substance use disorders have the ability to impact and activate the pleasure center of the brain. And repeated use of the substance, especially because it produces such an intense and strong activation of that reward system of the pleasure center, triggers continued use of the substance to the point that normal activities begin to be neglected. This simply reinforces what was stated earlier, that the authors have now included gambling disorders in this chapter on substance-related disorders because of the remarkable similarities between how gambling can activate the pleasure center of the brain and substances activating the pleasure center of the brain. The substance-related disorders are divided into two separate groups: substance use disorders, which we'll focus on for the remainder of this presentation, but also the substance-induced disorders. As is implied, substance-induced disorders are conditions or disorders that emerge specifically as a result of the use of a substance. Anybody who uses too much alcohol will become intoxicated. So alcohol intoxication is a substance-induced disorder. Once the alcohol has been metabolized and excreted, then the disorder will resolve. The conditions here are conditions that can be induced by the use of a variety of substances. When the substance is discontinued or metabolized and excreted, then the disorder itself disappears. Diagnostically speaking, at this point, what you're beginning to recognize is that in order to identify a person as having a substance use disorder, you have to understand what the criteria are. We'll look at those 11 criteria in a second. You also have to recognize that we would distinguish between mild, moderate, and severe cases of a substance use disorder. So, for example, if the person has 2 or 3 symptoms out of the 11, then we would say that he or she has a mild substance use disorder. 4 or 5 symptoms, we would say they have a moderate substance use disorder. 6 or more, they would have a severe substance use disorder. Recognize also that diagnosis is done specific to the drug of choice. So if the person has 2 symptoms of disorders specifically because of the use of alcohol, we would say that they have mild alcohol use disorder. If that same person has 7 symptoms relative to the use of opiates, then we would say that they have a severe opiate use disorder. So that person would be diagnosed as having severe opiate use disorder, mild alcohol use disorder. So, to diagnose a substance use disorder, first, you're using your judgment. Is there a pattern of use that has led to either clinically significant impairment, problems that you've identified and or that the client has identified, or distress, again, identified by you, by the client or the people in his or her life, that is evidenced by or manifested by at least 2 of the symptoms that we're going to look at now that have also been present within a 12-month period. Symptom 1, loss of control. The substance is taken in larger amounts or over a longer time period than was intended. Symptom 2, there's a persistent desire or unsuccessful efforts to cut down or control the substance use. Criteria 3, they spend a lot of time either getting the substance, using the substance, or recovering from the substance. Criteria 4, the person has a craving, a desire, a strong intent or urge to continue to use the substance. Criteria 5, the person continues to use the substance, i.e. recurrent substance use, but it's now causing problems, and in particular, they're no longer fulfilling major role obligations at home, work, or school, or a combination of the 3. Criteria 6, the person is continuing to use the substance despite having problems, either social or interpersonal problems that have been caused by, or worsened by, or exacerbated by the effects of the substance. Criteria 7, I'm now giving up important things in my life, either socially, occupationally, or recreationally, because of my desire or my continued use of the substance. Criteria 8, I'm continuing to use the substance in situations where the substance use is presenting as a physical hazard, i.e. I'm operating machinery when I'm under the influence. Criteria 9, the use is continuing despite my knowing that I'm having a persistent, an ongoing, or a recurrent physical or psychological problem that has either been caused by the substance or exacerbated or made worse by the substance. Criteria 10, tolerance, which is defined in one of two ways. One is that I now need more of the substance to get the same effect, or conversely, because if I use the same amount of substance as I was originally using, I no longer get the effect I'm looking for. My body's adapted, I now have tolerance, I need to use more, or I won't get the desired effect. And lastly, criteria 11, and this is substance specific, but if I don't use the substance, I go into withdrawal. Withdrawal would be substance specific, so there's characteristic symptoms of withdrawal from alcohol, for example, that you look for as evidence of alcohol withdrawal. Those differ from withdrawal from amphetamines, and so you have to know the substance that you're looking for in order to accurately identify the symptoms of withdrawal. And the other evidence of withdrawal is that the substance is taken, a substance is taken in order to prevent the withdrawal symptoms. For example, alcohol is a central nervous system depressant. If I can't get alcohol, I take tranquilizers such as benzodiazepine, Valium, in order to relieve or avoid the withdrawal symptoms. There are a number of specifiers that you would be familiar with. One is whether or not there is or is not a physiological dependence. Some substances will be evidenced by a physical dependence, a physiological dependence, i.e. when I stop using, I have tolerance and withdrawal. Some substances there is no evidence of physiological dependence. Similarly, we're going to distinguish between early and sustained remission. Early remission is when the person has stopped using, and there have been no diagnostic criteria evident for at least 3 months, but it's less than 12 months. So I'm in a 3 to 12 month window of no criteria, but I haven't yet hit a 12-month mark. Once I hit the 12-month mark, I now am classified as being in sustained remission. I've been able to be symptom-free for 12 or more months. This is really the goal of treatment. We believe people will go into remission, and our goal is that they go into remission and sustained remission for actually ideally the rest of their life. A couple other specifiers: people can be in remission in a controlled environment. If I'm incarcerated, I can't use the substance, so my sustained remission is because I'm in a controlled environment. Or if I'm using a agonist, this is most common with the use of opiates, heroin, etc. But if I'm taking methadone or Suboxone, buprenorphine as a treatment assist medication, I can be in sustained remission on maintenance therapy. There'll be no more narration on the remainder of the slides of this presentation. There's simply a listing of the ICD-10 codes that are used for billing purposes. Oftentimes when we diagnose a client, in addition to diagnosing the client, we also put the code that corresponds with the diagnosis. Coding is primarily important for statistical and also for billing purposes.